Okay, hello guys. So today I'll be talking about the inflammation of pancreas, and this basically contains information on acute and chronic pancreatitis. Please bear with me with my handwriting. So let's look at how this is. Essentially, it's in 2 pages. I've compiled all the information in 2 pages. So let's go. Let's start with it. So essentially, when you talk about the inflammation of pancreas, both acute and chronic cases are initiated by the so-called autodigestion of the pancreas. And this autodigestion occurs because of the digestion by its own enzymes. So there are some protective mechanisms within the pancreas. One of them is the fact that these enzymes are always flowing, through the ducts, and also these enzymes are in their proenzyme form initially, and it's only when they come into the intestine that they get activated by the enterokinase enzyme that is secreted by the duodenum. So the enterokinase converts the pancreatic proenzymes into enzymes. It starts off with trypsinogen being converted to trypsin, and this trypsin then activates all of the pancreatic enzymes in the duodenum. So, what can happen is there can be a premature activation of this trypsinogen within the pancreas, and this could be because of a number of causes. It could either be the fact that enterokinase from the duodenum enters into the pancreatic duct, or it could be the fact that when there is a block in the exit or block for the exit of the pancreatic enzymes, the pancreatic fluid becomes stagnant within the ducts in the pancreas. This stagnation then causes a sort of activation of the enzymes, and trypsin obviously will get activated along with it, and this can cause activation of all other pancreatic enzymes. At the same time, some other protease inhibitors are also activated. So that is the basic principle. Now let us go for the acute situation. So in acute pancreatitis, it is sudden, it is reversible, there's inflammation and there is hemorrhage, and it can be idiopathic in etiology. The reason why I mentioned this separately over here is because I forgot to add it over here. But anyways, so let's look at the causes and risk factors. It's technically I gets smashed, which is I over here, which stands for idiopathic. G stands for gallstones, E stands for ethanol, which is nothing but alcohol consumption. And then T stands for trauma. S stands for well, S stands for two things. Number one is a scorpion sting, and the other S is for steroids. The use of steroids can predispose the patient to acute pancreatitis. M is for mumps. A stands for autoimmune diseases. S, as I told you, already stands for scorpion sting. H stands for hypercalcemia. So, increased calcium levels basically means that there will be more calcium within the cells. Therefore, there's greater chances of the signaling cascade to occur, because you also know calcium is essential for kinases activation in the signaling cascade. Stands for endoscopic retrograde cholangiopancreatography. This is basically some surgical procedure. D is for drugs. So sulfa drugs. RTI stands for reverse transcriptase inhibitors. This belongs to viral antiviral drugs. Then you also have some protease inhibitors. So um, let's get back to G and E because there's quite some explanation to be done. So G, gallstones. The main principle of gallstones is that it causes blockage of the like excretory pathway of the pancreatic enzymes. Therefore, they'll just be stagnant. At the same time, lipase is usually produced in its active form. So when there is stagnation, uh, this can cause lipase to act within the pancreas itself. It will cause fat necrosis, and of course, there will obviously be inflammation. With the case of ethanol, there are four things that are happening. The fourth one is quite interesting. That's why I put the stars here. So number one is that the sphincter of Oddi, right? Um, if you don't know, I can show it to you. So if you look at this, you've got the common bile duct. Uh, you got the common bile duct and the pancreatic duct. So over here, where they enter into the small intestine to the duodenum, there is a sphincter of Oddi. So when there is excessive contraction, it essentially means that the fluid within the common bile duct is not, being removed into the intestines. So yeah, and then also there will be increased zymogen secretion because of ethanol. Zymogen granules are present within the acini of the exocrine part of pancreas, which secretes the enzymes, right? And also at the same time, there'll be decreased fluid secretion. Therefore, it makes the entire uh, enzyme fluid complex very viscous. At the same time, there's decreased bicarbonate within the ducts. So that's the second part. The third part is ethanol, has an oxidative stress on the acinar cells of the pancreas. Therefore, there is inflammation. Then there is also premature fusion of the lysosomes, the lysosomes with the zymogen granules. And when this happens, the lysosomes, they'll act on the proenzymes present within the zymogen granules, and this will lead to premature activation of the enzymes, pancreatic enzymes. So that's that. So right now we mentioned the causes and the risk factors, which is I get smashed for acute. Let's go for chronic. Chronic, it's basically all causes of acute. Then most common in adults is alcohol abuse. Most common in children is cystic fibrosis of pancreas. Most common in developing countries is malnutrition. Then you also have autoimmune and idiopathic. Again, these two also belong to causes of acute pancreatitis. Now let's look at the pathogenesis of both acute and of chronic. Okay, so acute, basically I get smashed, literally mention the same, whatever I've mentioned over here. Just mention that. Also, just know that the proteases damage acinar cells, lipases cause fat necrosis, and elastases, they damage the vessels, and that leads to hemorrhage within the pancreas. So I would say this is a pretty important point. In the case of chronic, so number one, you have the causes, right? The etiology, which is I get smashed, malnutrition, AI, idiopathic. So the other one is that TGF beta. So TGF beta is also formed in chronic pancreatitis. So there are two things that are happening simultaneously. Okay, so yeah. So in the cases of this, in the case of cause and etiology, all the inflammatory molecules will, cause inflammation and they'll cause damage, which will then lead to replacement of the damaged tissue by fibrosis. Whereas TGF beta, which is also secreted as part of inflammation, it will activate, so plus circle means activation, it will activate the myofibroblasts of the pancreatic acini, and this will lead to increased deposition of collagen because myofibroblasts, and again, collagen means increased fibrosis. So fibrosis causes stenosis of ducts. At the same time, it can cause dilatations in other parts of the ducts. Just imagine, like, you have a duct, there's certain parts of the duct that undergo stenosis. So the ones that do not go stenosis will kind of be dilated, right? At the same time, there will be damage to the wall of the duct itself. So because of inflammation, and this will lead to decreased integrity of the duct, thereby making the duct larger and therefore dilated. And inflammation will also cause acinar cell atrophy. So, stenosis of ducts, dilatation in other areas, and acinar cell atrophy. So, fibrosis leads to these three parts. Now, let's go for pathology. So, again, you have acute pancreatitis and chronic pancreatitis. Now, let's go for acute. So, in acute, you can see two patterns of necrosis. Okay, you have liquefactive and you have got fat necrosis. If you look at the macroscopy, in general, the pancreas is swollen and it is edematous. At the same time, there will be ascites, collection of fluid in the GIT, like, in the abdominal cavity. And this fluid will be brownish in color, okay, and it also contain fat globules. It will be brownish because of the presence of blood. That's in case of just in general. Now, when we speak more specifically about liquefactive and fat necrosis, In liquefactive, what's happening is the pancreas is soft, okay, and there will obviously be hemorrhage. As I mentioned, there will be elastasis can damage the vessel walls as well. So there'll be necrosis, there'll be hemorrhage. This will lead to a combination of red-black pancreas. At the same time, uh, because there's liquefactive necrosis, the fluid buildup, which basically contains the pancreatic juice along with necrotic tissue and other fluids, um, they will get settled in a cavity, okay? And this cavity is usually surrounded by fibrous tissue. And if you've got fibrous tissue surrounding the cavity, ultimately it will form a pseudocyst. Uh, so yeah, that's that. Now, in the case of fat necrosis, when there is necrosis of fat, there is usually saponification of fat that also occurs. This can lead to yellow white spots. Why yellow? Because obviously there's fat. Why white? Because there's calcification of fat that occurs along with saponification. Now, microscopically, typically like acute inflammatory signs, very basic necrosis, blood vessel necrosis, parenchymatous necrosis. Just mention that. So when you combine all of these, you will get three different variations of pathology: mild, severe, and most severe. And all of them have got acute, okay, in the names. All of them have got pancreatitis. P stands for pancreatitis. The only difference comes in whether it's interstitial, necrotizing, or hemorrhagic. So in interstitial, you'll have edema and fat necrosis. In necrotizing, you'll have edema, you'll have fat necrosis, and whatever else is mentioned over here, right? Maybe blood hemorrhage as well, but it is mild. Whereas in hemorrhagic pancreatitis, you'll have all of the above: edema, fat necrosis, hemorrhage, bloody ascites, pseudocyst formation, um, everything, plus dramatic bleeding. And that's what gives its name of hemorrhagic pancreatitis. Now let's go for the complications. So pseudocyst formation, okay. Then the pancreatic pseudocysts and also just the necrotized tissue can form abscess because of E. coli infection. They can also be shock because of hemorrhage. Trypsin usually activates prothrombin, which will then cause coagulation cascade, and this will cause disseminated intravascular coagulation. Then ARDS, acute respiratory distress syndrome, because pancreatic phospholipase destroys the surfactant, you know. And then you also have calcifications that occur due to saponification. So the peritoneum can there can be many different, you know, calcifications in the peritoneum. However, if this calcification is dystrophic, that is occurring in multiple areas and to a great extent, it's usually a sign of chronic pancreatitis. So clinically, what do you see? Okay, let's go for this. So, okay, zoom this in. Yeah. So clinically, you'll have three things. You'll have fever, nausea, vomiting. Okay, that's one. Second is an epigastric abdominal pain. So that's above the umbilicus. And this pain usually radiates to the back. Third, you see some signs. You have something called as a Cullen's sign and Gray Turner's sign. Cullen's sign is hemorrhage just above the umbilicus, therefore called periumbilical hemorrhage. Gray Turner's sign is flank hemorrhage, that is, it is present around the sides of the torso. There are more pictures in the next couple of pages, so you'll be able to see it. So, just three simple clinical situations. Now let's go for chronic. I don't know why I put this arrow mark. So macroscopically, it's firm instead of being soft. It's predominantly white instead of being hemorrhagic, yellow, hemorrhagic, whatever. But there can be a transition from acute to chronic where you'll see a combination of both. They'll mainly be fibrotic, so large amount of the tissue, pancreatitis tissue will be replaced by fibrosis. There'll be visibly dilated ducts, again, because the surrounding pancreas are destroyed. The ducts wall are weakened, or they can just be fibrosis around. So there'll be, pulling of the walls towards the fibrotic sides, and therefore there'll again be dilatation of the ducts. And the ducts will contain calcium deposits because of saponification of fat. And concretions. Concretions are like, you know, concretions, like deposition of the calcium in concentric circles throughout the duct. Now, microscopically, again, common sense, there'll be atrophy, there'll be fibrosis, it's extensive, there'll be dilatation, and also one important point is that usually the ducts will undergo squamous metaplasia. Then you also have chronic inflammatory signs. Now, clinically, what do you see? Again, typically you can have a transition from acute to chronic, so you can still see epigastric pain that radiates to the back, but this usually occurs after meals and can last for a few hours. Then there'll be mainly pancreatic insufficiency, where the pancreas is insufficient in performing its functions. Why is it insufficient? Because no more enzymes are being produced, because the exocrine glands of the pancreas or the pancreatic acini are destroyed. Then you have malabsorption, steatorrhea, and weight loss, because pancreatic enzymes are not degrading the lipids properly, and also enough chylomicrons are not being formed, and therefore even the vitamins like the absorb fat soluble vitamins, which is A, D, E, and K, are not able to you know be absorbed. Let me just cross check. Yep, A, D, E, K. Okay. Let's go back. Now let's go for complications of acute chronic pancreatitis. So we learned that complications of acute was mainly all of these, right? Now, in a patient with chronic pancreatitis, there could be a certain degree of all of these, okay? Because a full extent of all of this would have resulted in significant um, threat to life. But considering there's just, chronic pancreatitis, usually because of no more release of insulin, because even the endocrine glands will be destroyed and they'll be replaced by fibrosis. There will be type 1 diabetes mellitus where there's no more insulin being produced. And essentially, this is secondary diabetes mellitus because it's secondary to some pre-existing condition, which is chronic pancreatitis. Pseudocyst formation, of course, and this increased risk of pancreatic carcinoma, definitely. Now let's go for diagnosis. In the case of acute, the gold standard is CET. Okay, what do you see in the CT scan? Edema, necrosis, pseudocyst. Very obvious. Ultrasound, usually it's for gallstones. Okay, fecal elastase hypocalcemia can also be like identified. So basically, this is highly sensitive. Okay, it's also quite specific. Whenever there's an exocrine pancreas dysfunction, there can be elastase seen in the fecal matter. When there's hypocalcemia, there can also be tetany. Hypocalcemia usually occurs because whatever calcium is there within the body, they will be used in creating these calcium depositions. Then, if you look at the serum markers, you have serum amylase, lipase, and immunoreactive trypsin. In the case of amylase, it's usually less specific. In the case of lipase, it's more specific. But amylase can also be identified if there's some damage to the salivary glands. It can also be seen in the urine, whereas lipase cannot be seen in the urine. And because amylase can be seen in other situations like, tumors or some sort of infection to the salivary glands as well, lipase is more specific. Immunoreactive trypsin is usually the most sensitive. That's the case of acute. In the case of chronic pancreatitis, for the diagnosis, you do two things. Either you do ERCP, where it's, I forgot what it was called. Endoscopic retrograde cholangiopancreatography. Okay, so basically you're inserting a scope, it's an endoscope, and you're going in a retrograde direction from the sphincter of Oddi all the way up through the pancreatic duct and to the common bile duct. So you can visualize the common bile duct, you can see if there's any problem with the liver, you can see even the pancreas to a certain extent. So yeah, so you can use ERCP to identify the chronic situation of the pancreas, chronic pancreatitis. Other than this, you have X-ray and CT scan. They typically show calcifications. I have a picture in the coming slides. Um, yeah, and then you go for treatment. Acute, chronic. Acute and chronic, always remember pain control. Like start thinking from a most basic like perspective. You have pain problems, there'll be hydration problems and electrolyte balance needs to be maintained. So provide hydration, provide electrolytes, ask them to not consume alcohol. Either no, or I can also put decreased consumption of meat. Then they also have to reduce obesity. Okay. Then you can provide replacement of the enzymes, even hormones like insulin, for example, and nutrient supplementation, such as, yeah, any like whatever deficiencies are present. In the case of acute pancreatitis, also they have to make sure that their bowel is getting some rest. So usually you have to go for nutrition via IV. You might have to provide oxygen supplementation and antibiotics to prevent pancreatic abscess formation or even systemic infections. So yeah, that's basically the overview of inflammation of pancreas. Okay, you have acute, you have got chronic. This is in general like the description. Remember the causes and risk factors, and from that, just mention about the pathogenesis. I hope everything else is pretty much clear in these. It's like I've stuffed everything into one paper, so it can seem like it's a lot, but I think with the case of if you manage to put some time and read this, then revision becomes very easy. Here are some pictures, like, you know, so you have gallstones over here, you have gallstones here. You can use ultrasound to examine them. Usually the tissue is inflamed when you find gallstones over here, so you have to suspect, um, pancreatitis. So perform a CT scan. Um, yeah, and then you can also go for, you can also look at this picture. So you can see there's areas of necrosis. I'll zoom in actually. So there's areas of necrosis here. There's some cyst formation. It could be a duct as well, but this big, it's probably a cyst. There's, all these white areas, which is calcifications. There is fatty replacement of the tissue. You can see some more fat here. Okay. Uh, I think this is just the momentum probably, or surrounding fat. I think this is a duct. Okay. Again, you can see that it's kind of not normal. There can be some fibrosis in this area. Here you can see replacement of the pancreas by fat, and you can also see areas of necrosis over here. Over here, there's some hemorrhage. Oh, of course, there's definitely hemorrhage in these areas as well. Literally, such huge parts of it are covered. Uh, just going to erase all of this. Okay, cool. And then you can see some symptoms: upper abdominal pain, so epigastric pain, pain radiates to the back, pain that feels worse after eating. This is usually because the pancreas are forced to secrete their pancreatic juice after eating. So, the sort of constriction of the acini, the movement of fluid through the ducts, all of this can contribute to the pain. There's usually fever, it can become systemic. There's rapid pulse, there can be nausea and vomiting for sure. Okay, and then idiopathic, get smashed. Um, Here you can see this the umbilicus. This is the cranial side. This is the caudal. So Cullen's sign is periumbilical hemorrhage. And then Gray Turner sign is on the torso, so towards the side. So probably the umbilicus is somewhere over here. This is the torso. This is the leg. Um, yeah. And then other possible causes for differential diagnosis can, in case of women at least, can be ectopic pregnancies, ruptured spleen, ovarian cysts, you know. And again, this is some more information. You have criteria as well for diagnosing. Okay. You can check for serum amylase, serum lipase, serum immunoreactive trypsin. And if you do imaging, okay, so you're doing a CT scan here, which is the gold standard, by the way, for acute pancreatitis. You see these. So these are all calcifications. Okay, this is the pancreas. Now, here there's a pancreatic pseudocyst. Again, gray Turner sign, so flank hemorrhage. Um, and remember, current sign is periumbilical, or like just above the umbilicus. And this flank hemorrhage usually occurs because of retroperitoneal hemorrhage. The pancreas part of it is also retroperitoneal. Therefore, bleeding can occur behind the peritoneum. Okay, and yeah, and also greater intestine usually takes about 24 to 48 hours to develop. Here you can see chronic pancreatitis. There's typically fibrosis. The pancreas becomes small. It's surrounded by fat, which then undergoes calcification. So you can see a lot of calcification here. You can see that the pancreas has become atrophic. Here there's just some more information about in acute pancreatitic event. It's just the asteni are pretty much like this, but then with chronic pancreatitis, there's more fibrosis that occurs. And yeah, there'll be dilatation of these ducts. There'll be possible biliary obstruction. There can also be venous thrombosis, which can also cause DIC. Okay. Yeah, that's about it. So thank you, and I'll now also be sharing with you cystic fibrosis of pancreas.